We'll be touching on a lot of the same themes that Steve and John covered, but from perhaps a slightly different perspective. Talk a little bit about the hazard analysis. One thing we're looking at here, we're touching about Ebola, right? But Ebola is far from the only emerging pathogen that we're concerned about. These things are popping up on a regular basis. They have been. We just get better and better at IDing things. So this is just a list of things that have emerged really from 72 up until about 2000. You see the original Ebola outbreak back there in the late 70s. And that was really our first introduction to it. But if you look since then, we've got things like SARS, we've got things like MERS, a variety of others. This really ends up being a very global perspective. The world is a much smaller neighborhood than it used to be, okay? All it takes is literally somebody getting on an airplane and they can be pretty much anywhere in the globe within a matter of hours. And this is a big concern, particularly for things that are highly transmissible. Just again, to show you kind of where things are actually popping up. And I'll introduce this term of both emerging and re-emerging, because some of these things we had on the ropes once upon a time, but they've managed to find a way back to re-emerge into either new geographic regions or reappearing in the same region due to a collapse or a lack of vigilance in terms of our control strategies. Just to kind of point out again, to give you a basic idea of where some of these things are and where they're coming from, why do they show up? Okay, so really there are three basic things that have to be there for one of these emergence events to occur, right? You've got to have a source of the infection, okay? That can be an infected individual, it can be an environmental reservoir, it could be an animal, okay? Most of the things we're talking about in terms of recent emergence, a lot of them are zoonotic. Okay, a lot of them are coming from a new type of interaction with animals in some way or other. You also have to have the susceptible population. Okay, you've got to have hosts that can receive the agent and let that agent initiate an infection. And of course, in my mind, the most important and where we have the opportunities for controls, or the best controls in my mind, is really in this route of transmission, right? And if you look at this as a whole, you're really talking about an ecology of disease transmission, okay? You got to think about this from an ecological standpoint. So how these emerge is basically some type of change in ecology, okay? That's what causes an emergence event. It could be a change in the host. A virus decides to jump from a bat to a human. It could be a change in exposure. People start cutting down trees and start coming into contact with animals. It could be a change in the pathogen itself, a slight shift or mutation in the case of, say, influenza. Or it could be the fact that we're just better at picking things up now, okay? The good news, bad news is if something tends to be relatively lethal, we end up being pretty good about trying to figure out what that is. We put a lot of effort into it, even though it may affect only a few people. And so our recognition of highly transmissible, highly dangerous diseases is quite good. Of course, here's the bug we're talking about today, Ebola. This is in the order Mononegoviralis, which means it has a negative RNA genome, single-stranded. It's in the family Filoviridae, the genus Ebola virus. Okay? Only 5 species of Ebola virus. And you can see most of these have been named basically on where they were first observed or isolated. The vast majority of these are highly infectious and cause human disease. There are a couple, excuse me, I don't know which one there, Restin. Restin is one that gives us a little bit of a relief. It doesn't really, not as infectious in humans, largely shows up in macaques. Okay, so it's named after Reston, Virginia, where there was an outbreak in a macaque facility, but is actually endemic in areas of the Philippines. Yes?
Yeah, there was a recent study that showed that a few genetic changes in Reston can increase the
just a few. Exactly. All it takes is just a few shifts in base pairs, and all of a sudden you've got a different surface conformation allows infection that's much more virulent. So even though it's not as serious as the rest, certainly would still be something we'd be worried about. The original outbreak, again, was in the late 70s in Zaire. This was originally kind of African hemorrhagic fever. excluding an outbreak in 2000, there were roughly only about 1,500 cases. So it wasn't really a big issue. Okay? However, this current West African outbreak in Liberia, Sierra Leone, and Guinea made it a big deal, made it a global event. Okay? We're at, what, 28,000, almost 29,000 cases, half of those being confirmed cases. That's the other thing about these outbreaks is in a lot of cases, we don't bother to confirm all the way out. The symptomology is such or the outcome is such that we just chalk it up as, yes, that was Ebola. Okay? But there are a lot of other things that circulate in these areas that can have some similar symptomology. And then there's, of course, the concern that you might have multiple agents as well. Probably most disturbing to all of us is the fact that there were 36 exported cases into 7 different countries. Again, all it takes is one person getting on a plane. You can be anywhere in the world very, very quickly. Includes 4 cases in the U.S. with the 1 death. Again, if we look at this from an ecological standpoint, the predominant thought right now is this really arose from a human interaction with bats. And in fact, if we go out to look at bats, there are a lot of things that they hold that can make people sick. Okay? It's not just Ebola. There are a variety of other viruses we find as well. But in this part of West Africa, they eat bats. Bats are a food source. And this is where people are actually coming in contact with the initial exposures in all likelihood. The bad news is that once this gets into a human host, it spreads very rapidly between hosts. And so it's really this clinical spread that amplifies the outbreaks and makes it a much bigger deal. Really leads to a longer endemicity, okay, or kind of natural spread within the human population. Of course, this isn't the only bug, though. Ebola is not the only one we're worried about. You guys are probably familiar with coronaviruses. They're named coronaviruses because they've got this nice kind of crown-like appearance when you're looking at them under EM. They are a completely different type of virus. They have a single-stranded RNA genome, but it's positive sense, not negative sense. So slight differences. You guys know the difference between positive and negative? Not that you'd need to, but the difference is a positive sense acts like mRNA. It gets in the cell and is off to the races. Our negative sense has to get in and basically transcribes itself first, okay, before it can do anything. By and large, coronaviruses weren't thought to be a big deal. Okay, 10% of the common cold was usually what we used to think of the human coronaviruses. There were a few bad actors in other animals, things like mouse hepatitis virus for mice, bad thing. For us, not usually a big deal. But as we've started grouping these and kind of breaking them out, we started to find certain groupings, particularly the beta coronaviruses, had a very wide host range. And as we started seeing things like SARS popping up, we started seeing real concerns with the coronaviruses as a very significant pathogen. Of course, you can see the inadequate PPE that people kind of throw up in terms of protecting themselves. This was all over the news when SARS happened. SARS isn't the only one in the coronavirus we were about. Also coronavirus, or MERS, or Middle Eastern Respiratory Syndrome coronavirus. This one's now been reported in over 21 countries. Has a really low sustained human transmission, so the endemicity in humans is probably not going to be a big issue. However, there was a cluster in Korea that was quite significant in terms of the human-to-human transmission. This one, like Ebola, probably originated in bats, although camels may also be a significant reservoir that lead to a direct exposure in humans. This one is actually even a little scarier than Ebola because this one's truly respiratory. Okay, this one's likely to be spread by respiratory droplets, more of an airborne spread, and has a very high case fatality rate. If you look on per country basis, it's anywhere from 15 to 60%. It's 44% in Saudi Arabia. Certainly not the only viruses. We could go on to this list forever. There's the influenza virus. Of course, the big issue with influenza is the fact that we get reassortments, and we periodically have things like avian flu show up, okay, or swine flu, or some other mix where we have essentially a naive population. The humans aren't used to seeing the type of virus that gets into us. If it gets deep into the lung, causes a very severe illness. This, prior to Ebola and MERS, was really the driving force between a lot of our preparation, and still should be, because this is probably the more likely to have true global impact going forward, because it reassorts all the time. It's always changing. I'll throw one more up here, largely just because I want to pull in different routes of transmission, this idea of fecal-oral. The enteroviruses, okay? By and large, a very diverse group. It's been reorganized a number of times. Now we go from A to J for the enterovirus. We also group the old common cold virus within this group. Really, up until not too long ago, the worst actors in this group were polio. Okay? And polio was something that we now have on the ropes and near eradication. But every now and then we get a new strain popping up. Okay? This is enterovirus D68. This one caused a nationwide outbreak just a couple of years ago. However, it's been circulating since '87. It just all of a sudden started causing polio-like disease in certain cases, and that became a concern. This one certainly is shed, because it's an enterovirus, is shed very significantly through feces and passed through a fecal-oral route, in addition to nasopharyngeal aspirates or aerosols. Okay, so I've thrown a few questions in here just to kind of keep you active, because I know we're before coffee break, but after breakfast, everybody's falling asleep. So, what common factor linked the emergence of both Ebola and West Africa and MERS in Saudi Arabia? Okay, use your clickers, keep you on your toes. Okay, going once, going twice. See how many responses we get. 61%, the bat reservoir, exactly. Okay, so not that either of them don't shed in feces. In fact, we're not sure about MERS, but SARS certainly was shed in feces. We know Ebola is shed in feces, okay, at levels that we're actually concerned about. And you'll see some of that this afternoon. So these are our concerns. This idea of airborne transmission, this one we'll touch on again in a minute. But keep in mind, people were concerned with Ebola, particularly regarding airborne transmission. And we'll come back to that in a second. Let's talk a little bit about risk. Now, my perspective on risk comes from a much different position than the physicians and the clinical staff. Okay? If you look at risk, this is a great cartoon. I don't know if you guys have seen this before. This basic idea, and this guy was trying to depict the overall risk paradigm, right? So in this paradigm, you had somebody perceiving a risk, communicating it to others, and then their risk management was just to run away from it. Okay? That's not a very practical risk paradigm. Okay? What's missing?
Mitigation.
Prevention.
I haven't heard it yet.
Mitigation.
Assessment. Okay? He's perceiving, but perception is not assessment. You've got to understand what the risks are. Okay? Otherwise, your risk management is doing nothing but this. You're running away from it. You're just trying to get away from the risk as much as you can. Okay? So if you can understand the risk, you can properly mitigate. You can properly manage. Okay? So this is what we're going to look at. If trying to visualize in my own head just the process and the steps that you might want to take in controlling risk in an infection control setting, you certainly want to perceive the risk. You want to identify what the threats are. You want to go through a good and thorough risk assessment. Now, that risk assessment may mean different things in different settings. Okay? In the clinical setting, do you have time to go in and run computer models and all this? Depends. Okay? In the early parts of the outbreak and you've got new cases come in, you respond as quick and as however you can, just like John and Steve described. Okay? But as you can get out in front of something, and you can plan in advance, you can do a much more thorough risk assessment. You can run simulations. You can conduct computer modeling to understand exactly where opportunities exist to control your risk. Okay? That risk assessment is really going to inform both your communication and your risk management, and this is certainly a two-way street that's got to be maintained. Okay? Now, the thing is, from my standpoint, this is usually the paradigm I'm dealing in, the risk assessment, risk management, risk communication role. In the medical field, you've got to consider the patient needs. You've got to consider other cost-benefit analyses that really are going to influence your risk management as well. Yes?
Can I ask a quick question? Who wins in your life in the balance between risks of infection control versus care to the patient?
That's an awesome question. In a best case scenario, everybody wins. okay? Because you understand the risk, you understand how to mitigate, and you can maximize your benefits by minimizing your costs and still consider the risk. It's an optimization strategy. However, that is a very advanced kind of lot of forethought, lot of modeling, simulation to understand where that optimization is. And you don't always have that best case. So by and large, there can be losers, and you've got to understand where that is. I think it would probably go to the perceptions that you're dealing with, okay, in terms of patient care, the individual perceptions of their own risk, these type of questions. Okay, on to this idea of the risk perceptions. You can really think about risk perception along this kind of cultural theory that involves two axes. Okay, one of them is the influence of the group on social relationships, and the other axis is this kind of degree of constraint by the rules, right? And so if you kind of look at this XY plot, you can break people usually into fatalists, hierarchists, individualists, or egalitarians, all based on how they perceive individual risks. Okay, this is kind of basic risk theory. The thing is the type of risk may kind of push people one way or the other. Okay, so this is the question I'll pose to you. For the clinicians in the room, where do you fall? Kind of along the lines of what Paul's question was. You know, if you're a clinician coming at things, where do you fall? Which of these groups do you fall into? You know, do you feel like you have little control in the situation, it's your job, you just got to do it? Do you feel like you have the opportunity to kind of rank risk and pick and choose where you insert yourself? Do you feel like, really, it's my choice, I'm not going to go to work today? Where do you land on these things? Okay? Because if you look at the literature, since nobody's throwing up hands, if you look at the literature, it says that basically healthcare personnel are just like everybody else. Okay? The conclusion that this study had found was that public health organizations must consider the fact that health professionals are a group that cannot automatically be treated as an extension of the organization. Okay? People are people, and people are going to fall into one of those groups based on their individual kind of perceptions of risk. Okay? That doesn't mean that they can't perform their job, but their view of the risk in that situation will influence how they do their job and how willing they are to do these things. Okay? And one of the ways to kind of control that is to understand what's going into those risk perceptions, right? And so we consider these fright factors. Okay? Things that scare the pants off you, right? And I'm sure if we went around the room, there are very few things besides or beyond Ebola that scare us anymore, right? I mean, Ebola is one that's just, you know, bleeding from the eyeballs. How many people have read Preston's Hot Zone back in the day? Really? That's all? That's what got me in this field in the first place. You know, I found it fascinating. You know, this is a really sensationalized account, but as I'm reading through it, I'm going, I don't know if I buy this, right? So you've got to consider kind of what those fright factors are. And the press is very good about keying in on these because it sells papers and gets attention, right? So fright factors are something you've got to recognize, and the more that you can inform people regarding the risks, the more you can kind of overcome these fright factors and kind of guide people into how they perceive these risks. Okay? So again, the one piece that was, yes, absolutely.
Something I didn't see on your list that I think, especially being in an emergency room, that we noticed with healthcare workers is when you are so used to jumping in and saving somebody, having to stop and not jump in.
The reflex, yeah.
You know, we did a fantastic job of travel screening. Our nurses were just up front, really good at questioning everybody, walking everybody around outside through the rain. We have an external hot zone entrance. Mm-hmm. But we had a child come in extremis who actually had a pretty positive travel screen, and it all went out the window.
Because you had to help
They were
the kid.
rushed right back. I mean, you know, you had a screaming parent, you had a badly injured child, and everything, all that training went out the window. So it was very interesting to watch how there's also that piece of flipping into your save mode, which I think a lot of healthcare workers do.
Yeah.
And
so I think that falls more towards the behavioral and kind of overcoming training, you know. And I think if you look at these different fright factors, a lot of those go into the decision that those folks would have made, right? They're considering just how personal it is to them. They're considering, oh, it's a child. You know, these are all kind of factors that go into their own individual risk assessments. So whenever anybody's doing anything, you know, everybody does risk assessments all the time. Okay? The second somebody has to make a decision to interact or intervene in a situation, they're doing a risk assessment. They're doing the calculus in their head, and they're deciding what their cost benefit is, and you know, can they intervene? And they may overlook the costs altogether and say, this has got to be done, right? And so there's a lot of that can be going on. But keeping this idea of risk assessment, it is very different in different fields. Okay? In some circumstances, it is just qualitative as heck. You're making an assessment of just, there's a bad thing there, and I don't want to come in contact with it, or I don't want to be involved in it. So that's the very kind of just, you know, assessing what that risk is and just kind of drawing a line. Okay? That's the simplest kind of risk. The next would be kind of doing a risk ranking, kind of trying to assess just where the relative risks were. You know, then you get into more semi-quantitative identification of where those risks are. That's maybe what you get more in the clinical realm relative to, say, more of an IH realm. As you kind of go down the list, you can get into, say, deterministic type estimates of risk, where you start getting into actually assigning numbers to things, but they're just single guesses, okay, or single data points out of the literature, okay? And then on the best side, you would actually run probabilistic-based assessments. Okay? So the more data we get, the more we can actually populate distributions for the types of observations, and you can make predictions about what you think is going to happen and how much confidence you have in that. And that's the type of thing that if you have enough run-up, you can run these model simulations and you can really kind of identify where the potential to intervene is most effective. Okay? So the basic framework for that kind of quantitative approach is where I'd always like to get to, although I recognize that it's not practical to always do, is moving towards through the hazard ID, where you're really kind of not just identifying the particular pathogen, but understanding the disease progression, also formulating what the problem that you're wanting to assess is. Okay? Getting into an exposure assessment and a health effects assessment where we actually get into measurement and trying to understand the distributions and confidence, and then risk characterization where we actually start putting things together, okay, and coming up with an overall kind of population estimate or an individual risk estimate. Okay, so again, this approach is just really kind of field dependent. Okay, and so you're going to see this afternoon some approaches towards this FMEA. That is certainly a risk assessment approach. One of the approaches I take is called QMRA, where we get into quantitative microbial risks, and we deal specifically with managing exposures through the transmission route. So less from a clinical standpoint and more about the organism specific and the exposures of the hosts. So just another great cartoon, always trying to assess where the risk is. This is the most qualitative or I guess the semi-quantitative, the least quantitative of the quantitative type of approaches is basically just quantifying risks, okay? And you can see numerous circumstances. It is very effective for management strategies, okay? Simple color coding boxes, right? It's easy to understand. How useful is it to actually understanding the risk, okay? For the general population, maybe fine, but for people that are actually managing, you'd really like a little bit more detail than this, right? And so this is the type of output you would get with a QMRA, something that was much more distributive. You could actually assess the increasing risk relative to exposure or the levels of technological control, and you can generate confidence bounds, right? So this would be our kind of our median exposure right here at 50% probability of the event happening. This is actually for MRSA colonization in hog workers, of all things. But you can kind of predict what you think might happen, and then you can put bounds on it. And so you can assess just how much confidence you might have in those certain circumstances. And the great thing is when you're doing models that generate this type of data, you can make changes in those models. You can say, let's throw in a respirator and see what happens. And all of a sudden that risk shifts one direction or the other. Okay? And so you can play with simulations to find out what's the likely outcome. So looking at some considerations that we throw into microbial risk, you know, these are real differences between chemical risks. So those in the IH field right now, you've probably dealt more on the chemical risk assessment. Here's some key differences. One, a single microbe might be infectious. Okay? In theory, all it takes is one organism in the right place at the right time, and you got the opportunity to initiate infection. The bad news is we've also got secondary spread, okay? Because those organisms multiply in the host, sometimes they even multiply in the environment, although fortunately not viruses. And what will happen is the host becomes a source, okay? The case becomes a source, and you end up with secondary spread that we have to consider as well. And that can be done through a variety of network models and other types, basic SEIR type models. So, whatever type of risk assessment we're considering, one thing I want to point out for sure is host behaviors do matter. Okay? That goes not just to training, but goes to people's acceptance, just how cognizant they are, how tired they are. All of these type of factors will go into how we assess risk and how much confidence we'll have in our risk estimates. When we're conducting the hazard ID, the big things there, again, identifying the microbes, that's easy in this case. Okay? We want to understand the disease process and the pathophysiology. You know, what's the risk of the outcomes that we might be interested in? And we want to really understand those transmission routes. And this is where I said we'd come back to it. There can be a considerable amount of confusion regarding transmission routes. Okay? Things aren't always transmitted by a single route. Okay? Things aren't always shed by a single pathway. Okay? So you've got to be cognizant of all the different possibilities. When we say person to person, what does that really mean to you? Well, some people might think that's an STD type thing, right? Some people might think that's very close, intimate interactions. Some people might think that includes the indirect transmission through, say, fomites. Okay, so if we throw up fomitic or surface-related transmission, is that person to person, or is that its own type of pathway? And so as you start reading through the literature and you're trying to understand these diseases, you see a lot of these different things popping up, and it's not necessarily intuitive to delineate between them. Take the one of real concern is this whole respiratory airborne aerosol droplet pathway. Okay? This is a spectrum. Okay? But how easy is it to delineate between those for the general populace? It's not. Okay? It is a real concern. When we start dealing with these different routes, you've got to understand how it's going to enter the host, how it's going to leave the host, and really what's happening in between. Are there different vehicles or vectors involved? Okay? Is it airborne? And by airborne, I mean, can just droplets move through the air, depending on how those droplets move through the air? If it's a big droplet, what's going to happen? It's going to fall out and it's going to be on the surface. Does that mean it's no longer a threat? No, because then you've got the fomite and auto-inoculation route. Okay? If it's a really small droplet, what's going to happen? It's going to travel in the air, and it may stay in the air a very, very long time. If I were to sneeze right here, how long would this droplet stay in the air? Not very long?
Depends on how snotty you are.
Okay, mucin levels do play an issue, certainly, and the coarse droplets certainly would plaster that table, hit Liz, hit this whole front table probably. But the smaller droplets, 12, maybe more, 12 hours, okay, may stay in the air. Now, in this room, is that likely to be an issue? Probably there's enough air turnover based on the fan back there that might kind of flush the system out, okay? What's another concern? The fact that some of these droplets are going to change in size, right? I'm in a nice air-conditioned environment, relatively dry. My respiratory tract is a very wet, warm environment. As I expel those droplets, what's going to happen to them? They're going to go and get real small, real fast. Okay? That's going to make them stay in the air longer. Okay? Same thing happens the other way, though. As it goes in, you inhale in, those things tend to be a little bit hygroscopic, and they start picking up moisture. Okay? So if we talk about where things deposit in the lungs and how likely it is to initiate infection, you've also got to consider just where it's going to drop out, right? And that really goes to the removal mechanisms, whether it's impaction and interception, these type of things within the lungs, and that's all about particle size. Okay? So with Ebola, this spectrum of aerosol to droplet to surface kind of transmission was bungled by CDC. There's no polite way to say it. They really did not do this very well. And in fact, this document changed at least 5 times within a period of weeks. okay, in terms of what was available online. Okay, they kept making iterations, largely not because they didn't understand it themselves, but because they weren't communicating it effectively to the population. And the population was interested. They wanted to know, kind of how they were going to be exposed. Okay? And what they needed to do was basically show that this is a spectrum. Okay? And that it's all the same thing, is just in different degrees. Okay? It's shades of gray rather than black and white. It's not all kind of surface droplet. It's something in between. And the fact that the environmental factors play a role in where you're at on the spectrum make it really difficult to delineate that Ebola is or is not aerosol or airborne transmitted. Okay? The likelihood that if I were to sneeze here and Ross in the back is going to get Ebola, not realistic, right? One, it's not being excreted in high levels through our respiratory droplets, probably. It's more blood, fecal waste, other body fluids that are not as easily aerosolized. But from here to there, very possibly airborne spread. Okay? The droplets are going to move through the air. Yes?
Was it definitively worked out that it did or did not ever transmit via a droplet
No.
respiratory route?
Because it's really hard to delineate, again, where that case is. How can you delineate whether somebody was exposed and inhaled versus on the surface and auto-inoculated level? This is really the spectrum that we've got to consider, and the precautionary principle would say, you consider the full spectrum. Ross, did you have something to mention in particular?
I just want to remind people to use the mic.
Yeah, okay, thank you. All right, so then the next step after we kind of understand those transmission routes and the organisms is we start moving into assessing the exposures. Okay, and this is really, I think, you step back, kind of what the FMEA is going to help with this afternoon. It's going to understand what the behaviors are and where these interactions and potentials for exposure occur. I deal with it from a slightly different standpoint. I start trying to factor in and putting numbers on things like where the source is, what the shedding levels are, what that means in terms of occurrence in the environment, looking at routes of exposure and the transmission potential, how many surfaces am I touching? If we had a camera here visualing out, looking at everybody, I could tabulate how many face touches you're doing and try to assess exactly what that distribution might look like. Okay, so there are a lot of numbers things that we'll try to do when we do microbial risk. We also want to include things like the efficacy of controls. Okay, and when we start getting into understanding things like PPE, engineered controls, disinfection, we want to understand and incorporate that into our risk assessments. And that's where the quantitative assessments really help you because you can put real numbers on things. Okay, when we talk about disinfection, okay, there's no silver bullet, right? There's just not something you put on and everything goes away. When you talk about putting a disinfectant on something, usually what happens is you're reducing it. Okay, you may be reducing it by orders of magnitude, but you're still just reducing it, and the likelihood when you're dealing with very high titer exposures is that there will still potentially be some there. So the exposure assessment basically just determines the dose. What's somebody going to be exposed to? The next step is really trying to determine what the response is from that exposure or for that dose. We call it the health effects assessment. Now, a lot of people would just kind of default and call this dose response. Okay? That is the main part, the main quantitative piece, but it is not the only part. You want to understand health outcomes as well. For things like Ebola, the health outcome that you're probably most worried about is infection, because at that point, source becomes a case, or a case becomes a source, and secondary spread's a big concern. But you could look at risk of mortality. The risk of mortality versus the risk of morbidity or infection are three completely different things. Okay, and so you really got to delineate in this health effects what the outcomes you're looking for are. This is a perfect world, right? This would be human rotavirus exposure data. Okay, we don't have this for most bugs, and the data we do have for most bugs is not as well behaved as it is for rotavirus. But this is just an example of what you really like to have. Now, for Ebola, there actually is some dose response data in macaques, and so we can actually generate these same kind of curves and kind of predict what risks are and try to get to what that infectious dose might be. Now, when somebody thinks of the infectious dose, what does that mean to you? If somebody said the infectious dose for Ebola was 10, What would that mean to you?
How much of the pathogen is required to infect somebody?
So how much was required to infect somebody? Who?
The host.
A host. Okay, is that informative?
Through what route?
Through what route? So route's important. Who's important? What else? What else is important? Is that same 10 particles infect everybody the same?
Strain.
Strain can be important.
Host susceptibility.
Host susceptibility is important. The fact is, there is a lot of variability in this circumstance, both within the dose and in the host response. And so what we can see is, higher doses generally have a higher probability of initiating infection. Lower doses, much lower probability. So when I say the ID or infectious dose is 10, am I talking about for 100% infection? Am I talking about a minimal infection dose? Or am I talking about an ID 50? And so the term infectious dose doesn't mean, it's not really informative, because most people are kind of either talking as an ID 50 or a minimal infectious dose. And so if we really want to understand things, we've got to understand what this curve looks like, or at least what we're talking about in terms of the infectious dose. And why is that important? Because again, if we're trying to put numbers on things and we're trying to institute controls and all we're doing is knocking things down, at some point we want to get down here. We don't want the levels being up here, right? Introduce this idea of acceptable risk, okay? And this is really just, how you define acceptable risks. And this is very different in the clinical setting than the environmental setting. It goes to your kind of question of, oh, it's a kid and, we've got to intervene. As far as I'm aware, in a regulatory setting, there is only one acceptable risk defined. Okay, and this is in a water setting, and basically the people at EPA did a back-of-the-envelope calculation of the lifetime cancer risk for a chemical exposure and extrapolated all the way out to an annual risk of diarrheal disease. Okay, and it was 1 in 10,000 per year. Okay, that's the only regulated acceptable risk. That has been kind of used and adopted by different places, but there's no basis for it. When you're talking about accepted versus acceptable, it's what the hosts, what the individuals, the host behaviors, how they're going to influence what risk they're willing to accept individually. And in most cases, we just don't understand it. Okay? We don't understand really what the acceptable risks are. When we start talking about biosafety and kind of clinical standpoints, by and large, any risk to a highly transmissible agent is unacceptable. We want to eliminate that altogether, but in reality, you can't ever eliminate risk. You can't ever get to zero risk, right? Except for no exposure whatsoever, right? All right, so regarding risk assessment, another question for you. Get your clickers ready. Which of the following are not part of the basic quantitative risk assessment paradigm? Going once, twice. See what people say? Exactly. Risk communication is really kind of a separate piece that we usually remove from risk assessment. In fact, in a perfect world, what we'd really like is people to wear different hats. Okay? In the real world, some people do wear the same or multiple hats and do the risk assessment and communication, but you'd like some insulation in that factor, and the fact that risk assessment is an iterative process. You can't just assess a risk once and assume it's always going to stay constant. It's got to be an iterative process that you've got to go back to. All right, getting to the worker protection part. Okay, everybody seen this before? Has anybody not seen this? All right, this is the basic hierarchy of controls that CDC, NIOSH, and others have kind of put together, and basically looks at how effective you can be in preventing a risk or an exposure. Okay, best thing, eliminate the risk or eliminate the exposure. Okay, just don't let it happen. Is that practical in a clinical setting? No, the risks are there. The exposures are going to be there. Substitution, replacing the hazard. Can we merely replace the hazard? We say, no, we'd rather you not come in with Ebola, just bring in the common cold. Not realistic, right? Not within. How about engineering controls?
Yes.
That's where we're getting in. And so John and Steve did talk about putting up walls, okay? Air handling, these type of things are engineering controls that can kind of help mitigate or reduce exposures to a broader population, Okay? I'm not going to focus on those. I'm going to focus primarily on these latter two, the administrative controls and the PPE. And I'm really just going to touch on some of these concepts and hopefully we can initiate discussions during the breaks. So looking at the administrative controls, first thing you have to look at is where are the regulations, right? And who's in charge of it? Well, OSHA protects workers. Okay? Clinicians are workers. They don't always recognize themselves as workers that are governed by OSHA, but certainly they are. Okay? That's the federal agency in the state. What's it called?
Labor and Industries.
WISHA. DOSH. Okay. Department of Safety and Health. Basically, under this kind of occupational safety and health, we have the general duty clause. Basically, you will provide a safe working environment. Okay. Other than that, it's the bloodborne pathogen rule, and that's really the only two sections you can interpret to involve microbial exposures at all. Okay. And in fact, most microbial exposures, with the exception of the big three, don't get any airtime at all. What are the big three? HIV, HBV, HCV. Okay, those are the ones that are held out as poster children for the bloodborne pathogen rule. Okay, does that mean those are the only bloodborne pathogens? Certainly not. Okay, so there are a lot of things passed by blood and other body fluids, and we have to consider that. Beyond the actual regulations, then we get into guidelines. And these are administrative controls as well, in that they're setting up recommendations on how we actually operate. And here I will direct you to the CDC, because the CDC guidelines are really probably the best thing going. That may sound funny considering the way they bungled the initial communication, but the site they have now is actually quite good. And it describes very much the proper procedures for PPE, as well as disinfection, waste management, and other procedures. Lastly, the institutional procedural controls. There's nothing at the federal or the state level that can really substitute for what you do in-house. Okay? That's really where the controls are going to have the most effect. If you have a very strong set of procedures, SOPs, you do training and simulations to understand what you're supposed to be doing, you're incorporating strategic breaks, you're consulting with both your infection control as well as your occupational health folks, then you're starting to get into a situation where you're going to control the risks as best you can from an administrative standpoint. Okay? Your workers may not even realize some of the basic OSHA concerns. Okay? Hopefully they've had bloodborne pathogen training at least. Hopefully that's all up to date and renewed on a regular basis, but not always. Things slip through the cracks, and so you've got to stay on top of these things, and you do that through rigid institutional administrative controls. Moving on to talk about PPE. Now, John and Steve already went through a lot of this, so I'm just going to kind of throw some of the basics. Of course, the basics for most of the things we interact with don't require a lot of extra controls. Lab coats, glasses, gloves. Okay, but as we start moving into more serious exposures, more hazardous agents, we start thinking about some of the more advanced PPE. Now, they threw them up, they talked about what they were, right? But what considerations do you actually have to think about when you're choosing PPE? Comfort, okay. You might be wearing it for a long amount of time.
Resistance to disinfectants.
Resistance to disinfectants, tear resistance, impermeability to spills. Okay, if somebody was just wearing scrubs, it's going to go right through, right? That's a concern, right? But by multiple layers, redundancy, a good thing. Lifetime of use, how often you swap things out. Okay, things like gloves, big concern there. Is a single pair adequate? No. CDC recommendations are at least double gloving. What do you put on the bottom? Do you just use latex? Who says latex? Why wouldn't you use latex?
Poor barrier.
What, poor barrier? It's actually a pretty good barrier, but it's
Allergies.
not.
It's the manufactured defects.
It's manufactured defects and chemical resistance. Okay? Durability. All of these type of things. Anybody ever pulled out latex gloves, put them on, your hand goes right through them? Okay? The age of the product also is a big issue. Okay? So you always have to check for integrity in any of these as you're putting on. Okay? So when we're donning PPE, good practice says, especially when you're dealing with highly transmissible agents, you've got to have somebody else there watching you. You've got to have somebody checking you because you can't make sure all your seams and everything are tight. Okay? Again, this was an evolving process. The basic guidelines now are you want full body coverage. Okay? That's the recommendation. Okay? It's not necessarily the case or achievable in all cases, particularly in more remote areas where they might be dealing with this disease. Here, certainly we can take good steps. Talk a little bit about respirators as we kind of go through here. Again, CDC's current recommendations, these are all very well laid out on their website, so I encourage you to go there. I should have had the link up here, but it's in the manual. So that. Talking about gloves, again, gloves, good against all hazards. There isn't one that's good against everything, so you have to understand what you're going to be exposed to along the way. They do have a finite life use, and you're going to have to swap them out, particularly if they become contaminated, you're going to want to swap out. Okay? And so that's going to happen immediately because you don't want to be passing the agent or spreading it within your work environment. What was that? That was a weird sound. So, PowerPoint, was that what it was? Oh, I don't even know why that's in there. Oh, good Lord. It's horrible. Absolutely horrible. I didn't realize I'd put that in there. So another big issue, hand washing and decon in between. Okay.
Proper technique of hand washing.
Proper technique of hand washing, but it's not just hand washing, right? So because if we're switching gloves in between, we're going to use a lot of alcohol-based hand scrubs. Okay, that's another reason not to be using latex. Alcohol will help break it down over time, make it more porous, more likely to have defects exacerbated and more exposure. So these are all things you want to consider. When you choose the right glove, chemical and biological hazards, certainly. In most cases, we're not dealing with these in this kind of setting. Certainly sharps are an issue, though. Okay, and so durability there needs to be a big issue, or a concern, or at least a recognition. And you need to consider the combination of all of these hazards, as well as things like allergies. Okay? Anybody in here have a latex allergy they want to fess up to? A few folks. Okay? This is a very real, very significant issue for some folks. Okay? So you need to consider that. Length and type of cuff. Why is this important?
Want to have full arm coverage.
That's right. You want to make sure that you have no skin being shown. You want to make sure you can tape the seams and have a good control, no exposure to the skin. Okay, so all of these are important. What about sizing and handedness? Has anybody ever used handed versus or ambidextrous gloves? Okay. What's the difference between handed and ambidextrous? Anybody know? What's that? That's right. So ambidextrous, the glove goes in like this. Everybody see my thumb? Flat with your fingers. Handed comes out here. It's much more ergonomic. If you wear gloves for long periods of time that are not handed, how's your dexterity? How's your hand strength and stamina? Reduced. Okay? In fact, you can actually lead to hand problems, particularly if double gloving. Okay? So this is actually something to consider long term. In terms of the extra couple bucks per box towards handedness. Sizing also a big issue. If you're double gloving, for sure, you're not want to go with an oversized glove. Making sure you have the right glove size and not a lot of extra room in the glove will increase your dexterity as well as prevent tears and things like this. Respiratory protection. Okay, this is just kind of good practice, particularly when dealing with things that might be aerosolized. The current recommendation is either an N95 respirator or a popper. Okay? Anybody ever worn either of these before? Good, fair number of you. What's an N95? Which one's it? It's this one down here. It's probably the simplest of the respirators that are effective for microbiological exposures. What's the concerns with that type of respirator? Fitting. Everything's about fitting. How well it's going to fit around on the face. If anybody has any facial hair, non-starter. Okay? If you can afford it, your best protection is probably the popper. Okay? You're not going to see these. These are the moon suits. These require the hoses from the ceiling you clip in. That's if you're doing the actual BSL-4 laboratory work. Okay? You're not going to see that in Washington, by and large. You might find full suits, but largely people are wearing poppers and hoods. How does a popper work?
Filters the air.
That's right. It's a powered air purifying respirator. The air is brought in through here, purified, and then blown outward across the face. Okay? And so you create a positive pressure environment around the breathing zone. Okay? So that helps. With this, you're purifying based on filtration right at, and you will have failures. You will see if you've done testing with these, you can actually see flow paths with microspheres if you inject them into a chamber, and you can watch the fluorescent spheres on the face in terms of where the lines come in and things like this. So fit is absolutely everything with these. If you have facial hair, use the poppers. As far as the types of fit testing, you can either do positive or negative pressure testing on them. A qualitative fit test is basically putting them on. This is not adequate probably for this. This is basically, can you smell the smoke? Okay? Not going to do it for your microbiological exposures. You want to do some type of quantitative fit testing where you're looking at pressure differences. All right? All right, so which of the following factors should be considered when selecting the right type of glove? Going once, twice, and absolutely all of the above. Okay, you guys are getting good at this. Moving on to containment. Okay, from a worker protection standpoint, this is one of your bigger concerns, right? Source is all about elimination of the source or minimizing exposure to the source is the best way in that hierarchy of controls. Biggest source that we won't worry about is going to be spills. Okay? First rule about spills is contain first. Okay? You want to either use absorbent pads, gelling agents, something to put on that spill to contain it. Okay? So that it doesn't move into other places, it's not tracked and get on other material. Next thing you want to do, decontaminate. And this isn't always very well quantified or in our SOPs. We've got to make sure. You can't just use the adsorbent pads and then pick them up and then assume it's fine, right? Best interaction, you're going to decontaminate with some type of powder disinfection or use a liquid disinfectant that's going to be compatible with your adsorbent pads and gelling agents. After that, you've got to remove the hazard, clean the system, and then disinfect. Is this decontamination the same as the disinfection?
No.
Why? Might be the same solution that you're using, but why are they not doing the same thing? Organic load. Okay? When you're dealing with a spill, by and large, it's not just the organism sitting there on the surface, right? It's a lot of other stuff. It might be blood, it might be feces, it might be some other bodily fluid that's going to interact with that disinfectant. Okay? And so the best you're doing here is to hope it knock it back a little bit, minimize the exposure during the cleaning event. Okay? Then if you want to, you can never really sterilize those surfaces with typical disinfectants. You have to use a chemical sterilant, which are really nasty and not safe to work around usually. And instead you're going to disinfect in that solution just to minimize the risk of moving the contaminant from place to place. Now, you know, the choice of disinfectant is something we'll talk about in a minute, but it's not straightforward. You can't just spray something on and assume that it works. You've got to understand what goes into that process. Talk first, though, a little bit about waste decontamination. This was an issue Stephen John brought up in this idea that you've got to consider the waste that's coming out of the hot area, right? That's the fecal waste. That is any of the medical waste. And how are you going to treat it? They mentioned the concerns over the seweraging, the sewering, that's the word. Yeah, it didn't come out right. Sewering of the waste and the concerns that Georgia had. Georgia, again, bungled that. by and large, we do believe that sewering is safe, except for possibly right at the immediate lift stations. And that's just due to grinders and things like this and the worker interaction. But that exposure is considered relatively low. There are good guidelines, just like for clinical personnel. There are now good guidelines for the PPE that wastewater workers would need to use when dealing with some circumstance like this. But remember, there's all kinds of things in the sewer already, right? And so this is a type of virus that's not particularly robust in the environment, and so we can move on. As far as decontamination, though, if it's contaminated and has not been disinfected, it is considered Class A waste and is regulated as a hazardous material under U.S. Department of Transportation rules. If you provide adequate autoclaving and incineration, then it is not and is no longer regulated and should be able to be transported and disposed of. Okay? There were issues in Louisiana where they wanted to landfill some of the waste after it had been incinerated, and Louisiana wouldn't allow it because they were worried about the potential for exposure. This is the problem with risk perception, is they didn't understand the risks they were perceiving. Okay? Autoclaving, I'm not going to get into a lot of details, but it's not a straightforward thing either. You've got to make sure, particularly if you're doing red bags, this is a problem because this is close tight, and with autoclaving, what kills things? The steam penetration. And so if you have your bag sealed tight, you may not get the inactivation that you're thinking you're getting. Okay, and so you're going to want to run controls to make sure that works.
Question.
Yes?
Are your autoclaves for highly infectious waste materials have to be in a facility designed for such, or can you use the same autoclave you autoclave other?
So the technology is the same, but the procedures, the administrative controls on how you're using it, and the exposures along the way will probably be different if you can afford it. You know, for instance, if you're running BSL-3, we don't have BSL-4 in this state, so if we're running BSL-3 waste, usually that's a pass-through autoclave.
Yeah.
Goes in hot, comes out cold,
Right.
right? Whereas the question was regarding whether or not the same autoclave could be used for decontamination. In certain circumstances, autoclaves are expensive. You're not going to be able to really do it. So it's really that secondary containment getting to the autoclave that becomes the issue. All right, talk just the last couple minutes here regarding chemical disinfectants. I'm going to blow through a lot of this. There are a lot of factors to consider with chemical disinfection. You've got to consider the intended versus the labeled use of the disinfectants. How many of even hospital strength disinfectants are labeled with apply this to fecal waste and expect that it's going to work? It's not there. No, it says apply to the surface, let it sit for 10 minutes, walk away, come back, wipe it up. You know, these are the types of labeled instructions. That is the only legal way to use those disinfectants. And yet we routinely have circumstances where we need to use disinfectants in unlabeled uses. Okay? One of the big concerns in primate facilities in terms of how you deal with the waste coming out of them. Okay? So these are all big issues to consider. You want to consider the target microorganisms. Most disinfectants are tested against how many organisms? 3. 3 majors to get their initial label. Okay? They are generally gram-negative bacteria. If they want a virological labeling or a mycobacterium labeling, they will have to go in and test against those in order to get that labeling. Okay? If they want a label against Ebola, what's the rule there? Can they do that? Can anybody go in and do disinfectant testing on Ebola right now? Very few places. Okay? And so getting an EPA label with Ebola is really using something called the Spalding hierarchy. And the basic idea is Ebola is an envelope virus. It is considered a WIMP relative to the non-envelope viruses. And so the Spalding hierarchy, you got bacterial spores appear as the most resistant, envelope viruses down here. And the idea is that as long as you choose a disinfectant on this spectrum that takes care of something up here, everything below it should be taken care of as well. Now, always take that with a grain of salt, okay? Because there are organism-specific differences, okay? But by and large, Spalding is why we have labeling or recommendations for disinfectant right now regarding Ebola, because people haven't done the Ebola testing, okay? What they've done is either poliovirus, coronavirus, norovirus, something like this, and used it. As far as what some common surface disinfectants are, they might be quats, quaternary ammonium compounds, they might be phenolics, peroxygen compounds, that's like peroxides, chlorine species of various types, chloramines, chlorine dioxide. All of these have individual strengths. Some of those are kind of teased out in some of the slides that I'm clearly not going to get to, although I'll flash through them. You've got to consider that some of the disinfectants you'll see once they're commercially available are not just pure one of these or another. Okay, so one of the things you need to consider the formulation of your disinfectant to understand what the potential interactions are with the work environment as well as the worker exposure. Okay, so it's not as simple as just grabbing one off the shelf and spraying it. You need to talk to infection control. You need to talk to your occupational safety folks about the individual exposures. As far as quats, again, I'm just going to blast through these because I'm over time, but these are all there in your books that you can look at. These just kind of summarize both the mechanisms and advantages and disadvantages for the different compounds. In particular, I'll use chlorine as an example here. High oxidative capacity, it basically just burns things up from the outside in. So it takes care of the outside of the virus and then gets into the nucleic acid. Very effective against most things. Simple operation, it's inexpensive. The problem is it's highly corrosive, highly toxic, and a chemical hazard, okay, depending on how you're utilizing it and what pHs. And so you don't want to put this on sensitive medical equipment. Okay, so you need to consider, what you can regarding the efficacy of use, the stability, the corrosivity, and the chemical hazard. And there's some very key charts here looking at the overall biocidal spectrum, stability, corrosivity, and chemical hazards for these disinfectants. Those are all in your books. So with that, I'll end with one last question for you all. What type of disinfectant would you use to decontaminate a fecal waste spill? Okay, going once, going twice. The smart people say, absolutely. Okay, go find out from the staff who are supposed to know this. If you are that staff that's supposed to know this, refer back to those other slides and come talk to me and we can talk about some more of the specifics. All right, any questions, although I know we're over time? If not, yep.
I just want to say, I don't know if it needs to be recorded. We'll try to make, pertinent to our presenters' permissions, most of these slides available to you following the course, like in a PDF file, so that you can actually see better than the little snapshot in your manual. So
Yeah.
it'll be kind of a follow-up to the course. So if there's something in particular that you really like, we'll try to get this all to you.
Perfect. Yeah, and if there's any of the things I've referred to in the slides and you want more information, I can provide that too if you send me an email.